Hello and welcome to the Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution the conversations in this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in this episode, we discuss the Rezum procedure for the treatment of the urinary symptoms associated with an enlarged prostate, otherwise known as BPH. Rezum is one of the so-called MIST procedures, minimally invasive surgical therapies for BPH. Other such procedures include UroLift and Itind. So how does Rezum compare to these other procedures, as well as to more traditional surgical therapies such as TURP or laser procedures? What are the risks and benefits? How durable is the procedure? And probably most importantly, what kind of outcomes or improvement can someone expect from the procedure? In order to answer these questions, we turn to an expert in the Rezum procedure, Dr. Kevin McVary. Dr. McVary is professor of urology and director of the Center for Male Health at the Stitch School of Medicine at Loyola University Medical Center. Dr. McVary is the chairman of the American Urological Association BPH Clinical Guidelines Committee and the co-chair of the International Consultation of Male Lower Urinary Tract Symptoms, and is the associate editor of the Journal of Urology. He has also completed a 4-year stint on the American Board of Urology Exam Committee. An experienced investigator in prostatic disorders and erectile dysfunction, Dr. McVary is currently and has recently been principal investigator for more than 75 clinical trials. Dr. McVary's research has generated more than 400 publications, including journal articles, books, book chapters, and abstracts. And now, without further ado, I bring you a conversation with Dr. Kevin McVary about the Rezum procedure for the treatment of BPH. Hello, and welcome to Better Man Clinics. Today, we're going to be talking about Rezum, a novel treatment options for men suffering from the urinary symptoms associated with an enlarged prostate, or BPH. Now, in prior episodes, we talked about other types of treatment options for BPH, ranging from what was always known as the gold standard, the TURP or the Roto-Rooter, to more novel treatments such as HoLEP or Itind, or even simple robotic prostatectomy. So what is Rezum and how does it fit into this spectrum of treatment options? What are the risks and benefits? What's involved? And how does it compare to all those other treatments? Fortunately, in order to help us answer these questions, we are joined by a true expert, Dr. Kevin McVary, who is not only a board-certified and licensed urologist, but also an expert on men's health and specifically on topics related to BPH. Dr. McVary, welcome to the program.
Oh, thanks, Oleg. It's a pleasure to be here speaking to you this evening.
Well, perfect. Thank you again. So before we jump into the topic of Rezum and BPH, one thing I love to do is to get to know our guests a little bit better, and for our viewers and listeners to get to understand who they're hearing from and who's giving them this information. So one thing I love to ask is, what inspired you to go into urology, the field of urology, and specifically an interest in BPH or issue of prostatic diseases?
Right. Well, I'll tell you, I'm what's known as a ureteral bud. My father was a urologist, and I was dead set determined not to become one when I went to medical school. And I fought and fought against that in my own mind. And then I had to do a required rotation in urology at Northwestern, which is where I went to college, medical school, residency, and fellowship, and was professor for 23 years. And I ended up in the greatest group of residents, and they just enjoyed themselves so much. And that kind of said, well, boy, I want to be like those guys.
Right.
And then in comes Dr. Grahak, who was the chairman of urology for 30 some years at Northwestern, and not just a wonderful clinician, but a wonderful man, and really stirred me. thinking about urology problems, urology questions. And so I spent a year in the lab working with Dr. Gray Hackett, Dr. Lee, Dr. Mizels, other urologists, and it really stimulated me. And so when I finished, I decided I was not going back to my hometown, and then I was going to stay and have a research career and try to better understand things like prostatic disease. Men's health essentially is where I focused. So, I ended up being one, even though I intended not to be one.
Human nature prevails. You were destined. You were destined for it, and here you are, right?
I don't know. I want to form a club of ureteral buds, urologists that were born of urologists.
Exactly. Well, that's amazing. It's an amazing story, and you obviously have a passion for your work that, despite all your best efforts, you still develop a passion for it, right? What can you do?
Right.
So, jumping in, thank you for that. That's fantastic. So, jumping in, we're talking today about Rezum, which is a newer type of procedure for BPH. I'm going to preface this. We've had the discussion before about, okay, when do we consider surgery for BPH? For people, some people, the medication doesn't work. Other people, they have side effects, and other people, they just want to get off the medication and do a kind of one and done or a few and done procedure. Now, the question is that, for years and years and years, when I was in training, which was not that long ago, I guess, although it is now, the gold standard was always TURP, or some guys call it the Roto-Rooter. So I guess a good place to start is, what is Rezum and how is it different from that gold standard or Roto-Rooter? Right.
So what is it? So it's a minimally invasive surgical treatment, a mist, designed to unblock the prostatic urethra in men whose prostates have grown large enough to obstruct the urethra. How does it do this? Well, through a camera, a cystoscope, a urologist inserts this instrument in the urethra, and at the very tip of the scope is a retractable needle. Urologist, once he strategically identifies, what parts of this prostate appear to be the problem, obstructive-wise, he presses a button, and this needle is delivered into the prostate tissue where he directs it. A small amount of water converted to steam, vapor, is then injected through the needle into the prostate, and it intercalates. It travels through the prostate tissues in a certain zone of the prostate that is where BPH occurs. Not the entire prostate, just what we call the transition zone. It can't travel into other portions of the prostate for various reasons based on volume, pressure, and capsule of the prostate. Anyway, in 9 seconds, that little bit of water or steam converts back to water, and in doing so releases this energy that touches the prostate cells and kills them in 9 seconds in a uniform fashion. So the urologist serially, he pokes this spot, pulls it out, pokes that spot, strategically positions the needle to steam these various areas of the prostate that look to be culprits. It's called convective steam. It's a different way of transferring energy. You don't have to worry about that. But long story short is, in 9 seconds, the poke is done, the steam is delivered, and the prostate cells that touch are irreversibly destroyed. And the average man takes 5 pokes. Each poke is 9 seconds. So in 10 minutes, this thing is done. So do it in the office, under local. Men can drive in, have the procedure, drive home. You can do it in the operating room and stuff like that too if you want. But anyway, a very versatile instrument, meaning, you don't have to restrict very much the types of prostates you treat. Depending on the one you find that day in the office, hey, you can very likely help the man.
So that leads to the next question. So, for a lot of prostate procedures, there's this prototypical ideal candidate and those candidates that aren't working very well. Is there an ideal candidate for Rezum, or is it just for all comers, basically?
Well, I would not say it's for all comers. By the FDA guidelines, it's for prostates between 30 grams on the small side and 80 grams on the large size. And why is that? Well, because in the pivotal trials that we did, the research trials for the FDA, FDA approved them, let's say, we did them. We positioned that we would only be looking at prostates within that area. And that's a pretty wide range of prostates, and actually it covers the majority of men. However, once the instruments and the technology has been approved by the FDA, the FDA doesn't stand in between a patient and a physician. It stands between a company and the patient. So as physicians, we can use our own judgment and decide, hey, in this man whose prostate is 90, could I use Rezum? The answer is absolutely. What about a man whose prostate volume is 100 grams? Absolutely. When I get above 100, then I'm having a talk with the patient that all these great things about Rezum that we know about and have proven, we can get into the great things later. Well, we don't have as much information when we get to very large prostates. So you have to couch it like, well, you're a little bit in untested ground, sir, in your 140 gram prostate, which is my personal limit. You might lose some of these advantages, early recovery, preservation of sexual function, these types of things, which are actually great attributes of the technology. When you get up to very big prostates, maybe that's not, we just don't know. And there are people doing that. The research is not as controlled. I'm doing it, and hopefully in a very controlled way. But so you wouldn't want to say it's a panacea. But if you choose the right patient, it's a very useful technology.
Well, it sounds like it is. And so again, it sounds like the sweet spot is between 30 and 80 grams, as you said. So 30 grams being, if you will, your typical prostate of a man of like, normal age, men after over 40, 80 maybe being 2-3 times that size. And kind of, as you said, you can go above. Now, aside from size criteria, are there any men who absolutely should not get a Rezum procedure? Any contraindications to consider for Rezum?
Yes. So, in my own view, treating men whose prostates have been irradiated is completely uncharted. And there are technical reasons, I guess, hypothetically technical reasons, why this might not be a good idea at all. And many patients who have received radiation to the prostate, who years later now have lower urinary tract symptoms, obstructive or not, it could be based on bladder problems from radiation. They come thinking Rezum is the thing for them. And I really have to dissuade them. I'm asked this a lot by other urologists. Can we use it in radiated prostates? I'll say, well, if you do it, you will be the first. And I don't really think scientifically I know scientifically it is not validated. And I think theoretically there might be some real dangers in a radiated prostate. If you look at the product inserts, it'll say men that have had a previous penile prosthesis, for erectile dysfunction. And I have done many men with penile prosthesis. I wrote the dang protocol in part, and that was excluded only because it made the passage through the FDA much simpler. But there isn't a technical reason an implant would be dangerous. If a man has an artificial sphincter, again, that is a contraindication. I would say, why are you doing a prostate procedure in a man with a sphincter? You look at the underlying diagnosis, something you're missing here, my friend. So, so those would be 3 runs. And of course, you wouldn't want to do it if a man had an active infection, just like you would never want to manipulate a man's urinary tract if he was actively infected.
Is Rezum something you can do on men who are on blood thinners?
Well, it has been done. But like all these blood thinners, the antiplatelet medications, the warfarins, the coumadins, you always have a better outcome if you can get the cardiologist to agree that it's safe to withdraw those, even if for a short period. I mean, it's just an easier course for the man. But to answer your question, yes, it can be done. I don't like doing it because they bleed more than your average patient, and that's what we'd like to avoid. So I always work with a cardiologist to say, what is, I don't want to say get away with, but what is still safe? How far can we withdraw these things and still be safe for this patient? Because it's going to be a better experience for the patient if we don't have bleeding difficulties.
No, for sure. And you had mentioned, okay, so post-radiation, not a great idea. What about men who've actually had other BPH procedures? If they had a TURP before, if they had a HOLA before, if they had a UroLift before, are there any contraindications in that sense? Like you don't want to redo the Rezum, or has that even been studied?
Oh, well, I've done it many times, and I'll tell you what I've learned. If it's a UroLift patient who comes saying, hey, I wasn't helped with my UroLift device, you have to ask yourself, was the diagnosis correct? So you really need to start from square one and reevaluate the patient objectively. I always scope those patients, past the camera up the urinary tract, because many times I'll look in, it'll be a UroLift which has been misplaced or encrusted, exposed metal, pull those foreign bodies out. I like to rest the bladder and prostate for a month or so to see, did the urinary tract symptoms improve? If they did, okay, are we okay now? If we're not, it's totally safe to proceed with a Rezum on top of the UroLift. Likewise, I've done it in men post TURP when there's bona fide regrowth or tissue which looks like it's naive, which was never treated. Same with a green light, patients with a green light. So each one of those cases you have to take, and it's a special group of men, and you need to carefully evaluate what's the source of their symptoms, what am I trying to accomplish? Is his problem obstructive? And if it's obstructive and there's tissue which can hold the steam, then there aren't really trials, they're just like case series, and there's evidence to support it's useful.
Got it. And so that leads to the next question. So let's say, I'm watching this podcast. I'm like, this sounds pretty cool. I'm going to see Dr. McVary and see if I can't get a Rezum procedure. One of the points of this podcast, that guys really like to know what they're getting into, and not only just from the procedure, but even for the evaluation. Like if a guy is coming to you just for evaluation, what do they expect in that first time they visit you in the office? If they say, you know what, I've got BPH symptoms, Dr. McVary, and I'm interested in Rezum, what should they expect in that first visit?
Well, they're going to hate questionnaires because I really try to use objective data to estimate exactly what are the symptoms, when is it happening, how long has it been happening? So query the patient as best as one can. If you're considering Rezum, and that includes an assessment of sex life too, because that's one of the attributes of Rezum, is its preservation of sexual life. And it's important to establish, well, how good are you?
Right.
This is not a magic wand.
Right.
So at any rate, lots of questionnaires to try and estimate that. And I would say very consistent with the AUA guidelines, and I'm co-chair of the AUA guidelines for BPH. That's a disclosure, I suppose.
Well, listen, it just shows that we got the right guy on this podcast, that's for sure.
Maybe so. Who knows? I would want some type of volume assessment, to understand, is the prostate this big or this big? And that's an ultrasound is a good way to do that. But if a man's had an MR, a CT scan in the recent past, like in the last year and a half or so, that's acceptable. I mean, I kind of give you the idea. And I actually prefer to do cystoscopy, a scope job, trying to make sure, okay, do we have the diagnosis correct? Is there an alternate physical process that might be mimicking BPH, like a stricture or a carcinoma in situ of the bladder, those types of things. And then I like to have some type of urodynamic test that demonstrates obstruction, meaning that this is a blockage problem from the prostate. It is not a bladder problem. Is it a pump failure, a pump overactivity, or is it a prostate blockage? And combinations are okay of those two, but it's just nice to understand, hey, I'm trying to unobstruct the prostate. If the bladder has its own problems, Rezum may or may, any procedure may not improve. It's actually 70% of men will improve if they have combinations. But if it's strictly a bladder problem and you're doing something to the prostate, maybe that's not in their best interest. And then I think there's something very cheap, very useful is a urination diary. Guys report. Yeah, I had a guy, he was telling me about how bad his symptoms was. He was drinking it. He was drinking a six pack of beer between dinner and bed, and then wanted to know, why did he have frequency at night?
Very strange.
It's your lucky day. You got an Irish doctor. I'm cutting you down to 2 beers a day. He comes back and he tells me I'm a genius. Like, that was easy.
There's minimally invasive therapy for you.
Right. But the idea is, some men can have nocturnal polyuria where their kidneys actually make more urine at night. And those types of simple diaries can really help either confirm, hey, this guy's got a problem, or wait, we need to look elsewhere.
Right.
And so those are kind of the simple things. So I look at the urine, of course, make sure this isn't, a glucoseuria problem where the men are diabetic and they're spilling lots of glucose into the urine. It can mimic urinate, BPH. So there's things that are standard, and they can expect that.
Well, I'm glad you brought all those up because, a lot of guys, they think, well, I go to the bathroom a lot at night. It's got to be the prostate. I need surgery, doc. Help me now. But you definitely don't want to undergo surgery for a different type of problem. The surgery is not going to help you with.
That's right. May worsen it.
Right, exactly. So that's why I'm glad you went over that in such depth, because it's really important not just to say, it's the prostate, let's get to work, let's do a procedure and stuff. Now, let's say we went through all that evaluation and you thought I was a good candidate, and we sit down and you're counseling me on this procedure, and pretend I'm sitting there across the desk from you, and I say, doc, what are the risks of Rezum, really?
Yeah, so it's in my own practice, 90% of them I do in my office, patients awake. So, there is that factor of, well, it's, can this patient handle the discomfort? And that's an assessment that we all make. You have a patient in front of you. Like, does this guy need anesthesia? He's nervous about everything, do I really want him in the office uncomfortable and having a bad experience? So that's one thing you have to decide, is the patient going to be able to get through it? And I've got a good team I work with, and my nurses and staff in the office, and we can get this done for most men. But some I say, you know what, I don't think you're that comfortable. You're anxious. I think we're going to do you in a ambulatory surgery center where they sedate you like if you had colonoscopy with propofol, those types of things. So that's one issue. A second is, you're putting the device in, you're poking it. Most patients will definitely have some blood in their urine afterwards. So they're going to have to understand that. And you always expect blood. Rosé's fine. Cabernet's fine. Clots, give me a call. So that's an expectation. There's a very low frequency of urinary tract infection after the procedure. And importantly, in my own practice, and I'd say in the pivotal trials, 90% of patients receive a Foley catheter. Why is that? Because if you inject the prostate with steam, initially there's a swelling, and that could be occlusive. And I don't want patients to plug off in the middle of the night and end up in a ER someplace getting a catheter. So, and I certainly don't want my patients in the ER during a pandemic. So I catheterize 100% of my men, or have them learn intermittent catheterization as an alternative. Many men, the men that do that are very, very happy, but this is asking a lot of some men. So I'd say retention is a possibility, although it's not really, because if you do the catheter, retention is not an issue. And then anytime you manipulate the urinary tract with a scope, with Rezum, anything, there's going to be some burning sensation initially when they pass their urine. So we call it dysuria, like burning sensation. And that's going to be the case. A colleague of mine from Houston, Ricardo Gonzalez, Dr. Gonzalez, you may know him, or that would be a guy for you to talk to. He's a great guy. He has this phrase that I've adopted. It says, for 2 weeks, you're going to wonder if you made the right choice, because the urination becomes frequent and urgent during that initial period. And then you begin, after the 2-week period, you begin to see the light at the end of the tunnel, like, oh, this is why I did it. So I warn patients, of that period of time. And Dr. Gonzalez has this phrase, you're going to hate me before you love me. And I think that's right. Like for 2 weeks, you're going to question your choice. Just have faith. Just have faith that we put the box around you. We understand you. We'll get you through that 2 or 3 weeks. Then you're in the part where the prostate begins to recede and the symptoms improve.
Got it. So I want to touch base on a few, I guess, perceived risks and side effects. So which may or may not apply. But the problem with the prostate is that oftentimes a lot of procedures and their risk gets conflated, and particularly with regards to BPH versus prostate cancer, et cetera. So I just want to lay it on the line here and just be clear. So a couple of things that about risks. First of all, is there a risk of erectile dysfunction after a Rezum procedure?
Yes. So I just published a paper on this, so I know the data pretty good. And if we have these questionnaires that we annoy patients with, where they repeatedly describe and rate their erectile function, we'll talk to that first. And it is a straight line across with very tight confidence intervals. That means very few men are getting better. Very few men are getting worse. Most men are completely unchanged. So by the way we can measure it, there is virtually no change now in erectile function. Now, what we did, which I think was enlightening, is in addition to having patients actually fill out these questionnaires, we also asked them in-depth questions about, have you ever had an episode of erectile dysfunction in the past? I mean, prior to your presentation for Rezum. And some men would say, oh yeah, a year ago I had some trouble, I got over it. And when you demarcate men that say I've never had a problem versus men that say, oh, a little while ago I had something, still sexually active, both groups, they separate, meaning the men that have never had a problem, straight across. The men that have had a history of sexual dysfunction, of erectile dysfunction, as time progresses, they're not as good at baseline as men with no history, and their slope is slightly different. At the end of the 5 years, it wasn't statistically different, but in order to say that, that some men got better, some men got worse. So you will have patients, it's less than 1%, that will say, yeah, my erection, it's not like what it used to be, doctor. And then you'll have guys countering that saying, doctor, I'm better. And then on average, you can say, well, the average guy, he's not changing.
Right. So I think it's pretty safe to say.
Yeah, that is erectile function. The other one, which in the past as urologists, we ignored completely, is ejaculatory dysfunction.
Right.
And there, the incidence of an ejaculatory, it follows the same course. It's a straight line across. If you separate men who have had ejaculatory dysfunction in the past from those who never had it, they track a little bit different. Again, that ejaculatory complaint is, again, less than 1% of men. So it's a small percentage, but it exists. So what does this mean? Well, patients have to understand that we're talking about a group statistic and trying to apply it to an individual. That's a statistical error. That's always fraught with danger, because the stats apply to the group, not to the individual. But anyway, long story short, there is this possibility. And although it turns out all treatments have this same risk, and doing nothing, placebo, has the same risk. In a sense, the men that have BPH are at risk for developing erectile dysfunction and ejaculatory function. If you look at placebo curves where men don't understand which drug they're being given, who have BPH, and follow them over time, that placebo just group, they're not getting any drug.
Going down.
Erectile function, ejaculatory function happens with age in men with BPH.
So
it's part of the landscape.
Of course. Let's unpack ejaculatory dysfunction a little bit. So by ejaculatory dysfunction, you're meaning here mostly retrograde ejaculation?
Well, I'm talking, well, technically I'm talking an absent ejaculation where no semen comes forward. Now, that can be from two causes. One can be retrograde, where there is an emission of semen into the urethra, prostatic urethra, but it goes the path of least resistance, and it can go up into the bladder. That's retrograde. Then there's an absence where there is no emission, where there's no semen, no semen coming forth out of the ducts into the urethra. Both get called a retrograde ejaculation, but they're actually separate. Medications like Tamsulosin, Flomax, Silodosin, Rapaflo, those medications induce an ejaculation. The ducts don't contract and there's no semen coming forward. So a TURP classically is a retrograde ejaculation inducing procedure. The semen comes out, it goes the path of least resistance into the bladder.
So let's follow-up question for that. So that's retrograde ejaculation has been one of the big bugaboos for TURP or Roto-Rooter, right? Because guys want to have an ejaculate. Now, as you mentioned, retrograde ejaculation after a TURP is because when I always like to describe a prostate like a big donut between the bladder and the urethra, and the urine has trouble getting through there. So you're shaving away the donut and opening up the hole. Now, that's exactly where the semen comes out. And as you mentioned, because there's no more donut and the semen, those ducts are much closer to the bladder, when you ejaculate, all that goes in the bladder and then you pee it out later. My question for you is, although Rezum works differently, it's accomplishing the same task, which is basically kind of getting rid of some of the inside of the donut to open up the channel. Why does it not cause retrograde ejaculation to the same extent?
It's a great question. And then I'll say there's kind of two developments, two new understandings for that. One is with Rezum, you try not to treat at the bladder neck where the prostate and the bladder meet. By design, you pull the scope back about 1 centimeter. It's called two fields of view, but basically you find where that interface is, that inner action is, and pull back towards the prostate to spare the bladder neck. And that is technically, every case, that's what we do. With a TURP, you don't do that. A TURP is designed to clear out that space. So not surprising. The other development is what's called apical sparing, where the distal portion, the portion of the prostate closest to the outside world, you purposely try to spare that tissue to preserve some of the ducts of the prostate, the ejaculatory ducts, which are in that location. You try to spare them to preserve regular ejaculation. And that's being done with green light and TURP. People are trying that with all these newer technologies, holmium, trying to preserve that area of the prostate to preserve ejaculation. I would say those are very good attempts. That's wonderful science. Rezum is certainly better at that, it looks like, and designed to be done exactly that way, spare those areas. And that's those two factors certainly do help, probably critical in terms of preservation of ejaculatory function.
Now, by sparing those areas, are you sacrificing a little bit in terms of opening up the channel and making it harder to pee, or not really?
I don't think so. If you do the Rezum traditionally, you must pull back from the bladder neck, and that's where the pilot data showed us you can preserve erection and preserve ejaculation. So I don't think so. but there's, people are even in taking this to, not to the extreme, but kind of the next step is, well, can we minimize the Rezum treatment to try and have no risk whatsoever in terms of erection and ejaculation? And this theme has a name and is called less is more. So less steaming is better sexual function. And I'd say at this point, it's a hypothesis that, but I'm doing that in men who come to me and say, oh my God, I really need a procedure, but please, my life will end if I have a change in my sexual function, ejaculation. They would accept that maybe they'll have less robust impact. And in those guys, I will do a less is more philosophy on them. It hasn't been aggregated and compared and studied. It needs to be. So basically, it's like a minimalist Rezum.
Right. But even with the basic Rezum, you would say that one of the massive advantages of it over the TURP or Roto-Rooter for men worried about their sexual function is that the statistics definitely show that it preserves that sexual function dramatically better than a Roto-Rooter or a TURP.
Yes. Yeah. Just for completeness, I'd say preservation of sexual function, ejaculation and erection, a quicker recovery, an outpatient procedure. You drive yourself in, drive yourself home, and durable. Very low retreatment rates of Rezum, 4.4% surgical retreatments at 5 years. That's really good.
That is good. We're gonna get back to that in a minute. I want to just, for the sake of completion, the last thing that sometimes you hear about with prostate, and again, this is admittedly more for prostate cancer, but also for TURP, is the risk of incontinence or leakage of urine afterwards.
Yeah.
Do you see a lot of that and or frequency, urgency, urge incontinence type of leakage afterwards?
To answer that, no. I mean, you don't see it. It's not less than 1%. It's zero. I mean, you just don't see it. Now, what you do see in the first, in the hate me phase, the first 2 weeks after the treatment, men have urgency and frequency there. I suppose if you're Jesse Owens, your urgency is going to be urgency. And if you're a slowpoke, it might be urgency and incontinence, but that is very transient. And that's a different, issue than, like a stress incontinence, where the sphincter has been injured, cough, strain, and urine come out. That I've never even heard of. So it's very friendly in that regard as well. The incontinence risk is minimal.
Got it. Now let's switch gears and say, okay, this all sounds pretty good to me. I think it's a winner. I want to sign up. I want to give the guys an idea of kind of the experience. And you shared some of this, but we're going to kind of go systematically through it.
Sure.
First of all, in terms of preparation, like obviously when you think about surgical procedures, there's a lot of preparation. You can't eat or drink before, and you may have to do some kind of prep or stuff like that. Is there any kind of preparation involved for a Rezum procedure, particularly, let's say, if you're going to do it in the office?
Well, most of the ones I do in the office, I do with what's called a prostatic block. So the preparation is similar to a prostate biopsy. They take an antibiotic pill the morning of. They take a Fleet's enema the morning of. They can eat food. It doesn't matter. I mean, because they're not being intubated or given an anesthetic. They show up at the office, and we give them an antibiotic shot. That's the AUA protocol for prostate biopsies. And I deliver, first thing I do is an ultrasound where I deliver a small amount of lidocaine in some of the near the prostatic tissues. It's called a beer block. It's a slightly different prostate block. And that takes about an extra 10 minutes, 5 minutes, something like that, pretty fast. And then that's it. That's the only preparation they need. Some want to bring a spouse with them. That's totally fine. They don't have to. I've had some physicians, urologist patients, they just came themselves. Okay, that's fine. I'd probably, if I was going to have my spouse come with me, but I'm probably whatever. wanted to hold my hand afterwards, knowing me. But at any rate, it doesn't have to. The guys can do it themselves. So there isn't a lot of preparation.
And okay, so you had mentioned in the clinic, you're getting this just really under local anesthetic. You've done the block, that you're putting the camera in. Scale of 1 to 10, how uncomfortable is that camera?
That has been rated. We actually did that. You know, at the beginning of the procedure, there's a little anxiety, but not much pain. It peaks up around a 3 or a 4 for a brief period. Occasionally, you'll have a patient who's 85, but brief period. And when I say brief, I mean a few seconds. And then that tapers right back down at the end of the case. That's good. So, I mean, I won't say it's painless. I mean, they certainly understand that we're in there, but it's, I would say, very well tolerated. They just, you know, you have an idea. If you have an idea of how the patient feels about it, if he's comfortable, then you know they get through it quite well.
Got it. And so you said after the procedure takes about 10 minutes, give or take.
Yeah. You
said that after the procedure, they get a catheter placed, they go home the same day. How long does that catheter stay in?
In my own practice, it depends on the day of the week I do the procedure.
Fair enough.
So like if it's on a Thursday, he's going to have the catheter till Monday.
Right.
Because I don't want him taking it out, and I don't want a patient in the emergency room. So if you did it on a Friday, it'd still come out on a Monday. Let's say your standard patient, 45 grams. If the prostate is much bigger and you had to do more steam treatments, we've learned keep that catheter in for a week. And we've actually made a little algorithm based on our database where we can kind of predict 80% of men are going to be catheter free by day 4. And I do nearly all my Rezums on a Thursday, just the way our office works and stuff. But the way where I have these rooms available to me. So these men are getting a catheter for 4 days. But in the trial it was 3.3 days, where we did not have that restriction. On the time of day you're going, or the day of the week you're going to be doing it. And bigger prostates, you know, they require more time. And again, that's part of the counseling process beforehand.
And then you said it comes out, let's say, in about 4 days, and that's when the I hate you phase begins, right? Where they're feeling the discomfort and whatnot. And then you said lasts about a week or so?
No, about 2 weeks.
2 weeks, okay.
2 weeks.
So, but during that 2 week period, they're still able to participate in all their regular activities. Do they have any restrictions or anything?
No, not really. No, get back to life. You know, I probably wouldn't take up horseback riding or bronco busting during that period of time, but
bad time to start bronco busting for sure.
Yeah. But you know, I mean, yeah, no, that's the whole idea. You know, go back. I'm not writing a note from work because you're going back to work.
Right.
You know?
Because there's really no, it's not a question of heavy lifting, driving, nothing like that, basically.
No,
so
you're not using narcotics during any of the procedures. So
yeah, you're basically, aside from the catheter, you're basically quote unquote recovered right after the procedure, basically.
Yeah.
Right.
Got it. I would say if there was a job where you didn't have a washroom, you know, relatively handy, then I'd say, well, you want to be sure that your frequency and urgency is not going to be impediment in your job. So that might be a caution, but that's more about how available is the bathroom to you at work than it is. It's certainly not a health risk.
Got it.
It's kind of a social interaction risk.
That makes sense. So, I mean, overall, it sounds like pretty well tolerated procedure, definitely kind of minimally invasive. You mentioned about durability. You said that, you know, I believe you said at 5 years, there's about a 4% retreatment rate, which sounds fantastic. Now, you know, a lot of guys listening to this, they might be in their 50s or 60s, and they say, listen, is this, you know, maybe I have 30, 40 plus years yet to live. 5 years retreatment sounds great. But is this one of the things like one and done, or do I expect to be redone in the next 10, 15, 20 years? Has there been data to show it? I know it's a pretty new procedure.
Yeah, so the data we have is 5 years old. That's where the pivotal trial stops. And if you look at the surgical retreatments, at 5 years, it's 4.4%. So pretty low. Now, what's interesting, if you look at year 2, it was like 3.7%. And then year 3, 4.4. Year 4, 4.4. Year 5, 4.4. So I'm not seeing the type of response we see from other types of myths, or what we saw historically from microwave or tuna, the older mist therapies, where there was kind of this steady degradation over time. With Rezum, we're seeing this plateau effect. And what I'm predicting is if there's going to be a need for a surgical redo, it's going to be early, not late. Because the curve just doesn't look like it's trending that way. Now, that's a prediction. I don't know that. We'll see what happens, but over time. But it's very encouraging to see that stable.
Certainly, and it looks like if you get past that certain couple of years, then it looks pretty like it has pretty good durability. Now, let's talk about success. Right?
Yeah.
What is your definition of success after a Rezum treatment? I mean, there's lots of ways to figure it out, but how do you judge success?
Well, I'm all tied up in the protocol and the way we declared it. And when you do a miss, the minimum improvement would be about a 25% improvement in the symptom score. That is like, in my own view, the low bar. That the FDA requires. We know from the pivotal trial that it's more like a 48% improvement in symptoms. So, I mean, we have lots of bonus room there. Nice. So, but ultimately, it doesn't matter how I feel about it, because, you know, the patient votes with his feet. And, you know, if a patient says, hey, I'm still bothered by this incremental improvement. Okay, well then, you know, see if we can work on that. So that will be kind of a discussion between patient and physician. And when I have those patients, I'm actually trying to tear apart, well, exactly what about, you know, your symptom score is 9. Why is this ruining your life when you started at 30? But, you know, trying to better understand that. But patients, you know, they vote with their feet. And so, you know, they tell me, oh, they're happy, or, you know, the converse is true. I look at it, I said, oh, you know, your score, you know, your improvement was X%. Oh, but doc, I'm so happy. Okay. All right, that's fine. Yeah. You know, if you're happy, I'm happy. I know you're safe. So, but anyway, what we expect is around call it a 50% decrease in symptom severity.
Which is pretty remarkable, really, given the minimal invasiveness of it. Do most guys who undergo Rezum, can they come off of their BPH meds?
So I would consider it a failure if they could not come off their meds. So yes. It is a disappointment if a man says, I stopped my tamsulosin and after a month I went back on, I thought I got, you know, that's a disappointment. Like, oh, darn. It's the vast majority of men are able to come off of it. We're actually publishing our own results for this right now, kind of real world, what percent of men come out. And we've coined this idea of trifecta, a 50% improvement in symptoms off all medications, no change in sexual function. So yes, to answer your question, yes, they come off their medications, and I have them stay on for 6 weeks to 6 weeks or so after. And that is, that's me taking data from other types of studies to this. We actually don't know that, but I think 6 weeks is probably the right time to keep them on their alpha blockers, their tamsulosins, their sialidosins, and pull those off after the 6 week mark. But
because assuming 6 weeks is kind of that key point where you're getting the maximal benefit from the procedure, where you're like the new steady state.
Starting to get in the love me phase. So we the curves cross.
Right.
So at 6 weeks they're crossing. So that's when we stop it. And every guy wants to stop.
Got it.
They all want to give it a shot. They're sick of these meds.
Sure. I mean, I think they'd be very disappointed if they would have to stay on them. for it.
I know their
Now,
doctor is going to be.
yeah, for sure. So, you mentioned a 50% reduction of symptoms, which again, on its face sounds fantastic. Have there been any studies comparing Rezum outcomes with those of that gold standard TURP in terms of just outcomes and success?
Right. So long story short, no.
Okay.
What has been done? Rezum does not have these it's a newer technology, does not have the same history as some of the other myths in which these were studies were compared with the TURP. Like a UroLift, there is a study, a 2-year study looking at UroLift versus TURP, and didn't go that so well for UroLift, by the way. That has not been done with Rezum. My guess, what I would anticipate, is that a TURP in terms of symptom scores will beat the Rezum in terms of the improvement in symptoms, but not on sexual function aspects and not on recovery aspects. So when patients weigh this, when they're voting with their feet, they're weighing, they'll say, no, I will take less robust impact on my LUTS if that means minimum side effects.
Right.
Western men do this and every part of their health. They'll gamble away some of the potential improvement to minimize the risk.
And that balance is critical, because this is a game of symptoms. Now, it's not cancer. It's not like a heart attack. It's about finding that optimal balance. Now, to that same extent, to compare apples to apples, have there been studies comparing Rezum to other myths like a UroLift, or Itind is probably too new for that, I'm sure, aquablation, but even to like UroLift, have there been head-to-head to show is one better than the other, either in terms of outcomes of these symptom scores or in terms of sexual function, preservation, et cetera?
No, not in a rigorous scientific way. I mean, there are a couple reports where guys will say, well, I did 10 this way and I did 10 that way. And that's not very valuable, because the urologist, just not trying to be devious, patients come in, he says, well, I think you're going to have a better result if I give you Rezum. Right. It's a selection bias is what the word is. Now, is there any comparison you can make with Rezum? I mean, it is new. Yes, there is, with medication. So we published a trial. Well, what we did is we did what's called a propensity weighting score. But anyway, long story short, we took the data from the IMTOP study, which was like the gold standard BPH medication study. And it was 3,000 men. For every one of those men, we found a Rezum patients to match them in age, prostate sizes, best as we can. You can imagine the statistical nightmare that this study was, called propensity weighting. But anyway, and then we followed the Rezum patients over this 3-year course as they matched with the medicine patients. And that was alpha blockers alone, finasteride, 5-ARIs alone, combinations, and placebo. And what you find is, in terms of symptom improvement, Rezum beats the medicines. In terms of flow rate, Rezum beats the medicines and placebo, as you would expect, and does a better job in preservation of sexual function than medicines.
No, it's a pretty compelling argument, right?
It sure is.
That are even on the medicines.
Yeah. So we're doing this right now for 5-year data. So if that was 3 years MTOPS, how does it look at 5 years? So we're in the middle of that right now.
Got it. Well, that's exciting work, and I think it sounds like it's helping a lot of people. Now, we talked a little bit about the what, the how, the why. I want to ask the who. Rezum is a newer procedure. It doesn't sound tremendously complicated, but I know there must be some type of learning curve involved, and for the doctor, actually the surgeon doing it. Is Rezum something that most or all urologists are doing right now, or is this something that patients should seek out an expert in Rezum, in your experience?
Well, yeah, I would say that they should seek men, urologists, and women and men. Men should seek urologists, not men. But sorry, don't get me in trouble here. But they should seek urologists who are interested in the problem and have experience. Now, I don't think I don't think that that it's necessary that they find the person in the world who has done the most. That kind of chase, I think, is superfluous.
Mhm.
And I mean, the Rezum technology is so interesting with its physics
Mhm.
that it's a little bit like horseshoes. You get the steam close,
Mhm.
and the physics
Take care
uh,
of it.
takes care of it. So
Yeah.
now, I mean, I think the judgment is that the critical things are you the right candidate for it?
Right.
Is the diagnosis correct? That would be, I'd say, more critical than have you done 1,000,
Right.
and we all get this all the time. I probably do it in my own life in other ways, but I would ask patients to resist that, hey, there's a urologist in front of you. He's concerned about you.
Mhm.
He understands the disease process. If he's done 10, I think you're good. You're good to go. There is a center of excellence process with Rezum. I think patients may migrate to that. Patients who are really health literate may migrate to that. I mean, it's published on the web. What the heck? But is it required? No, I don't think so.
Got it. Well, that's reassuring also, because it makes it easier to find. We interviewed Dr. Amy Krambeck a while back about HOLEP, and that's one of the big challenges of HOLEP is that there's just not that many urologists doing it. And in that procedure, you really want to have an expert, right? Because that's not one of those things where the physics will take care of it. That's for sure.
The learning curve is frightful.
Right. And so, she's a virtuoso, and for her, that's something that's, she, in her hands, it's amazing. But she herself said, that's the biggest challenge is, right, finding that right person to do it, because they really have to have experience. And so I guess another advantage here of Rezum is that you can potentially go to your local urologist and get a great Rezum treatment and a great outcome without needing to find the world's expert, as you say.
Thought leader. Right. Exactly. Exactly. I think that's right.
Perfect. Well, Dr. McVary, I think that's a good place for us to pause. I want to thank you for your tremendous insights and experience with Rezum. Before we let you go completely, I'm gonna ask you a question completely unrelated to your prostate, I think. So, this podcast is called Better Man Clinics for a reason. We really try to help guys get better in every way. And obviously you have reached a substantial level of success in your life. And the question we like to leave you with is, what's the secret to your success?
Well, I would say good mentoring is critical. And the other is, it's been an intellectual pursuit. I mean, I honestly do like the disease process. I like biology. I like medicine. And I guess I just came from a place where asking the questions, how things work, why they work, are fun. And I can't imagine I can't imagine doing anything different. So I'm so fortunate to kind of landed in the group that I landed with. So
all those years back when you were fighting it every step of the way.
But when I finally came to the realization, not doing it was as stupid as doing it because of who my father was, that once I got over that, then hey, boy, wow, did I luck out. Good mentoring.
Sounds fantastic. Dr. McVary, thank you again so much for your time and your insights. And for all you guys watching and listening out there, thank you for joining. And remember our mantra here at Better Man Clinics: your best life is a journey and not a destination. And use every single day to just get a little bit better. We'll see you all next time.
All right.